Welcome back to the Gillett Health podcast. We give you tools to develop a balanced approach for health. I'm Dr. Kyle Gillett.
And I'm James O'Hara, nurse practitioner. And today we have a bone to pick, don't we?
Yeah, this is going to be a dense podcast.
And we are talking all about bone density. So first of all, we know that hormones affect bone density, right? People talk about hormones this and hormones that. But what hormones should people be thinking about whenever they're thinking about bone density?
Yeah, essentially all of the classical hormones, for example, testosterone, androgens. Testosterone is your main androgen. Estradiol, it's your main estrogen. Growth hormone, IGF-1, even thyroid hormone. However, I'm remembering from medical school and residency how we treat bone density problems. And unless you're in adolescence, we don't use any of these, do we?
I suppose not. And you can even think of parathyroid hormone. I suppose that's one hormone that
does count.
Does have a place in bone density treatment in the traditional model.
Yeah.
But yeah, it's interesting. How does someone know that they have low bone density?
I guess if your parents told you you're big boned, then you have good bone density. And if they didn't tell you that you're big boned, then maybe not. But in all seriousness, the main way to track this is a DEXA scan, not necessarily the same DEXA scan as we talk about getting body composition, where they get a full body T-score, a full body bone density, or they tell you your total pounds of dry bones if they dehydrated them, but rather a T-score. And the ones that we care about the most are in the spine and in the femoral necks and in the hips.
Yeah, and those are the ones that you will get tested specifically if you are in the traditional medical setting. And what if you're a woman in your 60s, or if you have a family history, have been on glucocorticoids, smoking, some of these risk factors, then your doctor or your nurse practitioner might say, hey, let's check your bone density. And that will tell you very precisely where your lumbar spine compares to a healthy 30-year-old's lumbar spine, femoral neck, and so forth. You can get kind of a gauge on what your global bone density is with the DEXA scans we referenced that are at DEXAFit and many chains that perform the exact same tests that look at muscle mass, body fat, bone density, and some of them include visceral fat, which is a nice metric.
For that, you can go to DEXAFit.com or DEXAScan.com/locations. We unfortunately do not get any kickback of that. We will likely have a podcast sponsor here soon, though, so more on that later. But anyway, that's how to get a DEXA scan that would measure everything. But as you mentioned, the DEXA scan that's specifically looking at spine and the hips, that's what you get when you go to your regular doctor.
Yeah, and other things we think about testing, like if someone has a osteopenia or an osteoporosis that makes no sense in the clinical history of the patient, or just for thoroughness, a lot of times we will check a urine calcium, either a 24-hour or a calcium creatinine ratio to see, is this person losing calcium in the kidney? Because that can be a fairly simple fix with the thiazide diuretics. Mm-hmm. Caveat there, you want to make sure you're not losing sodium or you will actually impair bone density. So you may be thinking, we're saving the calcium, but because of the interaction of the electrolytes, you definitely don't want to be giving someone hyponatremia and setting them up for other consequences of that, in addition to impairing their ability to put back on bone density. So something to think about. Seems like everything is nuanced, isn't it?
Yeah, there is a lot of nuance to things. It's tricky like that. I guess I should stop my 2 grams of sodium a day diet while I'm on my thiazide. Anyway, some other things to check. Does this patient also have sarcopenia? Are they resistance training? What is their body composition like in general? Yes, obesity, as common as it is, does have an upside, and it is protective against osteopenia and osteoporosis.
Yeah, you are going to have more lean body mass if you are overweight or obese, and you're going to have more lean mass that's pushing and pulling on the bones, and you're going to be carrying around more weight, which is going to give your body a stimulus to hold on to some of that bone. So it is an upside, but it's not our recommendation or mainstay of treatment by any means. When we talk about physical activity, we'll kind of go in the reverse order here. We'll talk about a study that I've seen mentioned that I thought was just so unbelievable that there's no way that this is real. And the claim was all you have to do is jump up and down 10 times a day to fix your bone density. And I thought that seems like a very minimal stimulus. So we looked at the data, and there was a statistically significant difference between women who were jumping up and down and women who were in the control group. But the control group was losing bone density at an unprecedented rate in that study. And the changes were very small, I believe less than a 1% effect size. And it was within a very small time frame. At 8 weeks and 16 weeks, they checked the bone density. And realistically, if you're managing someone, probably no more often than every 6 months, probably best if you're doing it every 12 months to really get a gauge on how things are trending. So I thought it was interesting. I would consider this a bit of a passive-aggressive statement by the authors of the study. There were a significant number of participants that dropped out or did not complete their assigned jumping. And the authors said, apparently, jumping 20 times twice daily and waiting 30 seconds between jumps required too much time and effort from subjects. So I found that little gem in there and figured we'd throw it in because it's a bit comical.
Yeah, I like that a lot. I guess the control group had also either stopped their strontium before the study or maybe started GH. So there's very likely confounders to the study, but it's a decent start. I guess you could say, and this, by the way, this is maximal effort jumping, not necessarily jumping high. It wasn't jump rope where your feet are barely coming off the ground. They wanted them to jump high. And I believe we looked into the materials and methods, and they didn't have them squat all the way down, because it'd be nice if it was, a body weight, at least parallel squat, if not ATG, and then jump all the way up and down. But it's not necessarily translatable if you're going to do jump ropes and barely come off the ground.
Yeah, exactly. You need to have a stimulus there. So this is the example of a jumping stimulus that was used in a longer 8-month trial. This is actually called the Lift More trial, LAFTMOR, which I think is a great name.
Yep.
It's called impact loading. And a portion of this was what they called jumping chin-ups. So the person would grab a bar and then they would jump off of a box, and then they were instructed to, they jump up, lower themselves, and land as heavily and comfortably as possible, which sounds like a bit of an oxymoron.
Yeah, so putting as much weight on the ground and not the bar as possible, but maintaining comfort. That's an interesting one. So things to keep in mind. Where is the weight? Which plane is the weight going into? Is it going into the axial plane? Is it going to the sagittal plane? Whatnot? And yeah, that jumps out at you. That they're doing things that specifically load weight axially.
Yeah, and some of the other movements, they show the same thing, right?
Yeah, so deadlift, overhead press, and back squat, things that you would think of. Maybe not overhead press. Deadlifts, or certainly open trap bar deadlifts, is one of our favorite lower injury, high return on investment for stockpiling bone.
Absolutely. And, even if you're sitting on a leg press with 800 pounds on it, that's not going to do much for your lumbar spine. Great for the femurs, probably.
Yeah.
And the change they saw, again, small study, but a pretty intensive trial over 8 months. They saw, there was a, lumbar spine loss of about 1.2% in the control group, and in the high intensity resistance training group doing the jumping chin-ups, they had about a 3% improvement in their lumbar. Looks like about a smaller improvement in the femoral neck, 0.3%, but that's compared to a 2% loss in the control group.
Yeah, that was quite a bit of loss. Decent enough data here, although I think that there's in addition to this review, in our non-systematic review, there's a whole bunch of other articles that support similar protocols for both improving and maintaining bone density.
Yeah, and you definitely want to start sooner rather than later, stockpiling bone. never too late to start, but the sooner the better. And as we've mentioned in our past, I believe our synthetic estrogens and synthetic hormone replacement podcast, we talked about the effects of oral contraceptives on peak bone mineral density. So be sure to check that one out.
Yep.
What about supplements? Everyone wants to take a pill that's going to help them achieve their goals. And there's dozens and dozens of bone building supplements out there. So we looked at some of those ingredients, which ones work and which ones had more mystique to them.
The ones that likely work are vitamin D3 and vitamin K2, MK7 at an efficacious dose. A lot of companies do not have a high enough dose. Vitamin D, I'd say a high enough dose is to bump your vitamin D up, which for a lot of people is 5,000 or even 10,000, especially if it's not in a soft gel and if you're not consuming it with fats. And then for vitamin K2, it's likely at least 100 micrograms, but probably significantly more than that is an optimal dose in most people, especially if they're on a statin, which can deplete vitamin K2. So those are the first two. Another one that has been hotly debated among the functional medicine community is strontium.
And strontium will definitely improve your DEXA scans. It's questionable whether it's going to reduce fracture risk. That's going to be dose dependent. And strontium is really in this sort of interesting category where it is both a supplement and a medication. It's actually being prescribed again in the UK, or at least they have the ability to prescribe it again. I think that was late 2010s that came back into being able to be prescribed for patients. And then here in the United States, it's very common for strontium citrate at a lower milligram dose. Typically, you're looking at 2,000 milligrams of the strontium ranelate versus 680 plus or minus of the citrate to be used for the same purpose, to improve bone mineral density. And this is kind of a confounder. If you're looking at someone's overall bone density, you'll definitely see an improvement there, but you'll see an improvement regardless of whether or not they are resistance training, getting adequate vitamin D, calcium. So it can make it look like things are improving much more rapidly. And I would worry about someone just taking that pill over the person who is doing the resistance training, like the Lift More trial.
Yeah, you don't want to trick your doctor into thinking you have better bone density than you actually do. It's just like you don't want to trick your doctor into thinking that you have a much lower A1C that you actually do if there's a chance that it's pathologic. We went down a pretty solid rabbit hole here. And there's a lot of claims about strontium, and we like to validate or invalidate those claims. People know we have a very open mind, and we like to look into things. And we've seen claims by companies that happen to make strontium citrate that says strontium citrate is going to be just as effective, if not more effective, than strontium ranelate. And that just didn't appear to be true, because when you clicked on their link, it popped up, and the literature article did not cite that whatsoever.
Yeah, this blog, which can always be a red flag if you're looking at the validity of like something I read online, and people who are doing their research, be very cautious of blogs. They said strontium is the only trace mineral present in human bone whose level in bone correlates with bone compressive strength. And you click the link to their citation, and that citation mentions nothing of the sort, nothing about the strength in strontium, no correlation. So they essentially just made this up and put a placeholder citation in there, thinking, oh, people aren't going to click through this, or maybe ChatGPT wrote this in this day and age. Who knows?
Yeah, it could have been. Either way, that was disconcerting to see. Strontium does have some good data. For example, in human-made bone concrete formulations, it definitely has potential applicability. And it also has potential applicability in a situation where someone gets a DEXA scan, they've already been tracking their DEXA scan for a while, so they know, is my bone density stable? am I losing bone density? If so, at what rate am I losing bone density? And then they can add them in. And that way the strontium is not masking any other effect.
Yeah, because you could lose, say you lose 4% bone density in your lumbar spine in 1 year in actual density, but you're taking strontium. Because those are heavier, you're going to see in the DEXA scan that your bone density appears to have stabilized.
Mm-hmm.
So you definitely want to let your healthcare provider know that you're taking strontium. And if they are not aware, let them know that you are, this is likely to affect a DEXA scan, because not everyone is aware of this. Certainly nothing that was in my education in my nurse practitioner program, but something that I came across that, hey, this can falsely elevate the DEXA. That being said, it does seem to improve bone density and probably reduces fracture risk if we extrapolate from the ranolate studies.
Yeah.
But you can't say that just because it's citrate and not ranolate that you get all the benefit and none of the side effects.
Yeah.
A pretty good review here, I'll just kind of summarizes, says, there is no evidence to suggest that the ranolate has any different or more beneficial effects on bone than any other strontium salt. So essentially, I would suspect same benefits, same risk. So definitely be cautious if someone has cardiovascular disease or someone is at high risk for having a cardiovascular event.
Speaking of that, we also looked into that, and it didn't appear to be a definitive mechanism of action causation link. Perhaps it's because strontium often displaces calcium, and of course calcium and its action on calcium channels in the heart is important for the electrical conducting system of the heart. So perhaps it's not related to plaque buildup or strontiumodosis, just like you have amyloidosis. Perhaps it's not related to those mechanisms, but it could also be multiple mechanisms. Could be Occam's razor, could be Hickham's dictum.
Yeah, we really don't know the mechanism there. It hasn't been clearly elucidated, but those were seen in some of the RCTs. Observational data has had mixed results. So you definitely want to use caution when there's the unknown there, because we want to do no harm.
If only there was a complementary treatment that would decrease risk of cardiac events.
Still the number one killer. We must not have one.
For those who don't know, that would be HRT. That'd be estrogen replacement.
Looking at strontium ranolate, its effects on bone density, and then a 3-patient case report or case series, I suppose.
Mm-hmm.
We'll look at the comparison there. Strontium ranolate taken for 3 years consistently increased mineral density in the lumbar spine.
14.4%, I believe, in lumbar spine, and then either femur or total body, 8.3%. This was a New England Journal of Medicine study. 14.4% lumbar spine, and then 8.3 at the femoral neck.
Okay, perfect. There we go. And then if we compare that to people who were taking about a third of the milligram dose in strontium citrate form, so you have patient 1, total hip bone mineral density increased 2.7% the first 2 years. And this was after stopping alendronate, another medication we'll talk about, and continued to increase up to 9.2% above baseline after 6 years of treatment. So pretty impressive result. This would certainly fool some people if they didn't know the patient was taking this and they just saw the DEXAs and think, wow, this looks great. Patient number 2, an increase of 4.3% at the lumbar spine, 7.6% total hip within 1 year. At 5 years, 6.5% lumbar spine, 12% total hip. Stopped the strontium 1 year after stopping, lost 9.1% lumbar spine and 4.2% at the hip. So the effects on bone mineral density fluctuate very rapidly. In no normal physiologic state, even of very low estradiol levels without confounders like hyperthyroid or hyperparathyroidism, is someone going to lose 9% of their lumbar spine bone density in 1 year. So if you saw this, you would kind of scratch your head and think, oh, something's up here. Maybe it was a different machine, or in this case, it was certainly the patient. supplementing with the strontium and then withdrawing that supplementation.
Yeah, the third patient saw a pretty similar increase, 10% lumbar spine, 4.3% hip. And then after stopping, again, the bone mineral density decreased, essentially losing the progress and a bit more, 14% and 6%.
Yeah, so I think the way that I will incorporate this into my practice is making sure I have at least a year, say DEXA January, DEXA next January. What's our rate of bone loss? Have we stabilized that? Have we done everything we can? And then if the patient is low cardiovascular risk, strontium could be reasonable, especially if someone doesn't have extremely low bone density, if they're mildly osteopenic or not even osteopenic. If they are truly osteoporotic, then there are probably better treatments, other things that I would refer out to a specialist who's going to administer these. Usually monoclonal antibodies would be the standard of care now, or best treatments if payers cover.
Yeah. And as we mentioned, your bone is like both your bone and your muscle really are the 401ks of your health span. They're going to allow you to have the best chance to have a high quality of life very late into life. For example, at age 100, people who have high qualities of life often have excellent bone mineral density and lean body mass as well. So I guess that's, we might as well talk about different therapies like growth hormone. That's what people like to do in the 90s, the anti-aging molecule, MK677, its modern counterpart. The cure-all gives you less body fat and better hair, more bone, more muscle. What could go wrong?
Diabetes. But on a serious note, the MK677 is a growth hormone secretagogue. I would find it very unlikely that the benefits would outweigh the risks in this, because people do tend to develop insulin resistance. Some people pretty profoundly, some people not at all.
And hyperphagia.
Yeah.
In fact, you might get a bit of a benefit on bone just eating more, just becoming a little overweight.
A little heavier.
If you're not.
Yeah. And I'm also glad that they ran this study for a 3-year treatment period with an additional year follow-up. Mm-hmm. So the patients were on ibutamoren, MK677 for 3 years. The first year, they saw a decline in bone mineral density of the femur. Thankfully, we had some previous research with actual growth hormone treatment so that nobody said, stop this trial early, we're wasting away and losing bone mass, because that would have been very unfortunate.
Yeah, it's the bone remodeling process. So it remodels, and you see a dip with both ibutamoren, which I think is now Lume 201, and then same thing with HGH, an increase after more years.
This kind of reminds me of hair loss and hair growth.
Yeah.
So a lot of times when someone starts a medication that we know is very beneficial for hair growth, they have an initial shedding.
Yep.
And they think, oh no, this is making the problem worse. And then if you go back at 6 months, 12 months, in this case, you see a bit faster cosmetic result with the hair growth. Bone remodeling cycles as well. It looks like about 4 months would be the average. And growth hormone has to be given for at least 18 months before you see that sort of switch towards a net positive on bone density.
There was one study, and they looked at follow-up on growth hormone, 2.5 IU after 4 years, and there's an increase in total body and lumbar spine of 5 and 14%. So it's pretty solid, and you can see if you start stacking treatments, or even if you do have osteoporosis, if you get some biologics right off the bat, you can stockpile initially with what your best investment is. So you can put some money into your Roth IRA first, and then after you've kind of gone through that option early on, then you can start stacking other things off to continue to build up bone mass.
Yeah, and then you can, we'll put this chart up. I just think it's remarkable that this crazy increase you have at the time that the growth hormone is stopped in terms of an acceleration of the bone mineral density. I don't know that we have an exact reason for this. I just call it the lag factor. You have to take into account that you're going to see improvement 12 months after that growth hormone is stopped.
Yeah, presumably just less cell turnover, so less growth hormone. You have that reincarnation or life cycle is not going to be happen as much. So just like you see a decrease at the start, you get that extra little bit at the end.
Yeah, and then trying to figure out what a normal rate of bone loss actually is extremely difficult because the numbers are all over the place. Depends on what country you're in. Different ethnicities will have different rates of turnover. I tend to think that countries in Europe do a little bit better than the United States in terms of losing bone per year, meaning they lose less because they tend to be more active, doing things that are more osteogenic.
Like walking.
Even walking, yeah. It doesn't take very much at all to go from a very poor state of health for your body to a very good one. But annual rate, we say something like, 0.4 on the low end, maybe up to 1.6% per year on the high end.
Mm-hmm.
In some populations, maybe even higher than that. And lumbar spine loss seems to be a bit faster compared to the femoral neck.
Yeah. One interesting example of more rapid bone loss is during menopause and the menopause transition period, when it is often 10% a year or more.
Yeah, whenever you go from let's say you're hovering around a nice estradiol level of 100 in your perimenopause, and then that estradiol level drops to undetectable, or maybe it's in the teens, that will cause a shedding of bone, we could almost call it. And then it's not a linear drop off. 5 years out from menopause, 10 years out from menopause, you're going to see that process kind of slow and stabilize, not halt completely, but definitely slow because your body is kind of at this new homeostasis, assuming you don't put any hormones back in.
Yeah. But I've heard from WHI and OB-GYNs and all these women's health proponents or supposed women's health proponents that you lose all benefits of HRT, cardiovascular benefit, bone benefit. You lose all of that when you stop HRT. Now, that doesn't seem like it could be true, does it?
That's a good talking point. And we were talking about, I think a patient had actually gone to see a provider in the women's health space. And they said, well, why would you start something that you're going to lose the benefits of whenever you stop doing it? To which I replied, well, why would you start exercising? Because the benefits are going to go away if you stop doing it.
Yeah.
So, why would you do the dishes? You're just going to get dirty dishes again.
Yeah. Why would you stop smoking if the benefits are going to go away when you start smoking just a little bit? Just two cigarettes a day. I like playing this game. I've had discussions with many specialists because obviously our health optimization specialty, if you will, expands all fields and all organ systems in which you have to be well-versed to do a good job. And there's a lot of nuance to this. So you're talking about, this case, how many cigarettes a day that you smoke is concerning, or how many milligrams of nicotine. We can play that game. 1 milligram, 2 milligram, 3 milligram. Shout out to all of our listeners out there that use nicotine at a very low dose as a nootropic. So tell us in the comments about your 1 milligram per day of nicotine and how it has not exceeded that, or if it has exceeded that, tell us as well. But anyway, back on the topic, your benefit, the way I look at it is like if you had $1 million in your bank account when you retire, say you go through menopause, you can either lose 10% of that very rapidly right then at age 55.
Because you buy a vacation home. Probably not for those prices, but
whatever the case is, you lose 10% of that per year. So $100K per year. Or you can add to that bank account, or at least keep it the same at $1 million or just over $1 million. And then as you come off very slowly. And instead of losing 10% a year, you lose 2% a year. And the area under that curve of how much bone mass you have, and let's say you start exercising and doing axial loading resistance training, you're going to get way more bang for your buck investing in that resistance training if your bank account still has $1 million in it at age 59 or at age 64 than if it had 600K.
Yeah, and if you are, you shouldn't pick just one investment, but if you are picking one modality, then exercise is going to be the one with the best return. Now, it is good to diversify. I wouldn't put my investment portfolio 100% into strontium or 100% into vitamin D. Looking at those things that you take or biologics or medications, those are not going to give you the benefits of balance that you would get with exercise. And not falling becomes very important as you increase in age. My first job when I became an RN was in orthopedics. I saw a lot of people fall, and bad things happen after you fall, especially if you have a fracture.
Yeah, that's a good way to put it. And again, that's why exercise and diet are the two main pillars of health that have far more efficacy than any other pill that you can take, whether it's a diet or a supplement or any other pill or injection. We'll add that too. And sometimes in the obesity and fitness industry, exercise kind of gets a bad name. For example, Stan Efferding was recently talking about how sleep is better than exercise for fat loss. But what he was really saying is, don't miss out on sleep in order to do like stupid fasted cardio or something in the morning. Like obviously, if you're sleeping 5 hours, sleep 7 hours and then worry about what you're going to do. And in obesity medicine, it's well known that if people start exercising, that does not lead to weight loss, but it will lead to a lot of very positive outcomes like improved bone mineral density.
Yeah, even if your body weight does not change, someone who goes from being sedentary, I think that's usually classified as less than 4,000 steps per day, to even halfway following the exercise recommendations. So let's say they lift once a week and they do 90 minutes of aerobic exercise per week. A year from then, they're going to have way less visceral fat, probably less subcutaneous fat, definitely a bit more lean body mass and healthier lean body mass as well.
Yeah. Another modality or investment that we have not spoken about is bisphosphonates like alendronate. And we, I suppose, have to talk about this because my brother's a dentist and lots of our friends are dentists. And that's kind of the one that's known as a potential risk for major jaw surgery, osteonecrosis of the jaw, atypical fractures in general. And although this is a fairly antiquated med, for the right patient, it is reasonable. And for a very high fracture risk patient, then the benefit could outweigh the risk.
Yeah, and you think about the time of treatment, and you and I have talked about the subject of if someone's treated with this for a very long time, they're not having side effects on it, like it may make sense to help decrease that atypical fracture risk to take a brief drug holiday. And I suppose it's a risk you run anytime you are depositing bone in a non-natural way or a halfway natural way, instead of like having your normal hormone profile and having exercise and having, sufficient vitamin D, magnesium, and other minerals that are needed. If you just take something to increase the bone density, you get a net positive effect, but you can't quite replicate what the body is doing naturally. Now, that's not saying that this should never be done, that it's a bad treatment, or that any of these are bad treatments. But it's just something to think about in looking at the patient in front of you. Again, tolerability, I think probably GI side effects are the most limiting for these medications. Some people can't tolerate them for that reason.
Yeah. And it's the medication where you should stay upright after you take it. You don't want it to sit in your esophagus while laying down, taking this in the morning. We've actually already mentioned parathyroid hormone, a kind of bioidentical, I believe it's technically recombinant parathyroid hormone, as a treatment that is certainly a good choice for some people. And then we briefly mentioned Prolia and Evenity. Prolia's denosumab. And I'd say this is probably one of the go-to biologics for osteoporosis.
Yeah, and you can actually use these. Is it the same company that owns both of the medications now, I believe?
I believe so. I forget which one it is. They've probably bought us a lunch within the last couple of years. Maybe they haven't.
Yeah, not that comes to mind. But I do remember that this is probably even a year ago, you had told me about I think you were referencing the frame extension study, and that you start with the Evenity, follow with the Prolia, and that was shown to have really good results. I mean, if you look at
I was very impressed with the results.
Yeah, the outcomes there. And of these alone, you're going to see increases in bone mineral density and even significant enough to where you see changes in absolute rates of fracture that are pretty impressive, not just a like relative risk reduction, because it can be a game of, statistically. I don't know if that's a word, but we should invent one for that.
It's almost like there's
statistical shenanigans.
There's a lot of statistical shenanigans in medicine, that's for sure. And there's also a lot of synergy behind using a more reasonable dose or a shorter duration of exposure to a drug, and then using multiple drugs to help with that. And this is the case of it. And they must be owned by the same drug company, because for 2 brand name medications, companies, if it was 2 different companies, they wouldn't try to find a synergy between the 2 of them.
They would say, my drug is the best, or no, my drug is the best.
Yeah, they compare them head to head instead of try to use both. So if it is 2 different companies, props to whoever ran that study, as there is pretty good results. I believe they also, and most of these studies do look at fracture risk, but for both bone density and fracture risk, Prolia and Evenity have good data, even over a short time period of 1 year.
Yeah. And another thing to think about is the compliance. Like we were just talking about the GI side effects with bisphosphonates. And you don't have to have perfect compliance. And I think this applies to a lot of different concepts. But even if you are doing something 3/4 of the time, there's still a net benefit there. It was interesting to see some of these charts. And obviously there was a trend towards people who are taking something not at all or just 20% of the time. They don't have great results in terms of improvement or fracture reduction risk. But if you were doing the right things for your health in general, you're getting 3/4 of your workouts in, you're tracking 3/4 of your meals, sleeping well 3/4 of the time, it's going to be a lot better than not paying attention to any of those things aside from maybe January, 1 month out of the year, new me.
Yeah. And we may even put up a chart in the non-adherence study, because the outcomes were very impressive, even if you took your medication, whether it's a bisphosphonate or whatever else. If you took it half the time or 60 to 80% of the time, there were some very impressive results in those studies. And I like how they subgrouped the types of adherence into persistence and compliance. So they're very different, but regardless, if you have a pulsed dosing protocol, which of course would not be on label, but if someone does, for example, pulse their bisphosphonate, they have drug holidays, so it's extremely reasonable to use a pulse dosing protocol. Then you could have most of the benefit without most of the risk.
Yeah, and you're certainly not going to get 100% of the benefit, but pulsed regimens, like in our recent rapamycin podcast. And I guess you could say it is sort of a pulsed regimen, since this is something people are taking on typically a weekly basis. But extending that window, I know you're referring to, like maybe it's every 2 weeks, maybe it's once a month. Anything to get some sort of a benefit there and decrease the potential side effects. But pulse regimens, I think they are up and coming, especially with these medications that can be given more infrequently. That's certainly the trend with the more laser targeted therapies like the monoclonals and even siRNA therapies and ASOs, things like that we should probably podcast about in the future.
Yeah, we will have more on that coming in the future. I think that's been a pretty good summary on bone mineral density. Hopefully our humor was not too dense for you. And as always, thank you for your time, and may God give you health and happiness.